This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health. Hey, Rational Wellness Podcasters. Thank you so much for joining us today. And we have a very interesting topic. We're going to talk about birthing and all the issues related to that in the United States. I want to give you a little intro about this, but first I want to ask you, for those of you who enjoy the Rational Wellness Podcast, please go to iTunes and give us a rating and review so more people can find out about it. Okay, so despite spending more than twice as much for healthcare as other developed countries, maternal mortality rates in the U.S. are rising. They're much higher than all these other countries. And whereas maternal mortality rates are declining in other developed countries. So, for example, the maternal mortality rate in the U.S. is 26.4 deaths per every 100,000 live births, whereas it is 3.8 in Finland and below 10 in every other advanced country except ours. Infant mortality rates in the U.S. are also significantly higher than in 20 other developed countries. To help give us some information about this topic, as well as other information about how to have a healthy, happy birth, Ann Margolis is an international speaker, birth educator, certified nurse midwife, licensed OB/GYN nurse practitioner for over 20 years. Hi, Ann. Welcome.
Hi.
And can you tell us a little bit about yourself and how you decided to become a midwife?
I started out as an OB nurse. Actually, my grandfather was an obstetrician, and but I never thought I would be in that world. I didn't know. I ended up in nursing school, and when I did my obstetric rotation in college, I knew this is what I wanted to do. And my first job, now this was back in the 80s, my first job as an obstetric nurse, I worked there about 4 years. And that it was a regular, typical, standard hospital, and that's where I developed fear of birth. I was having to rescue a lot of the problems caused by just routine interventions that are done to all healthy women walking in to have a baby, let alone people that have complications, right? But most women are healthy and having healthy pregnancies, and they were just getting the routine care, which led to a whole, often led to a cascade of interventions that caused problems, that caused more interventions. And as the nurse, I was having to do, rescue that and do that. And I was having to be at more operating rooms than I ever imagined. I never really saw natural birth like I was taught about in nursing school. And so I had fear of birth. Birth was a crisis. It was an emergency waiting to happen, a disaster waiting to happen. It was a potential lawsuit. That was the experience on the unit where I worked. So of course,
sad.
That's all I knew, right? There was no internet then. That's all I knew. And I was pregnant with my first baby on this unit. So I was given the royal treatment. Oh, one of our nurses is going to have a baby. And but I was given the standard treatment. And what I want to share with you is my experience, because it's still going on today, despite all the evidence again about the harm of this kind of care. And this is what, gave me the passion to do what I'm doing. So I had fear, and I went in, and the first intervention that seems innocuous is I was told to take off my clothes in labor and put on a hospital gown, which is what we all do. It seems harmless, right? But that begins the disempowerment, and I feel like sick when I'm a healthy woman having a baby, and I didn't really know this then. I was just, I'm now in a hospital gown. I'm dependent, disempowered, kind of like an assembly line patient. And now you guys know everything. I know nothing. That's what happens when you put, so I tell always people when they go into a hospital, keep your clothes on, at least, retain your power, your individuality. But anyway, so then I was told you can't eat or drink. And any athlete knows when you're doing any sort of major event, you do not, it's not wise. It's actually totally not advised to go without oral fuel and hydration. I was attached to an IV. Labor is a major physical event for the body. I quit, it's like running the 26-mile marathon or climbing, a big mountain. It's very arduous. So you need to be hydrated and nourished. I was told I had to lie down flat and be attached to continuous electronic fetal monitoring. Now, the electronic fetal monitoring that monitors every contraction and every fetal heart rate, they're doing this routinely, despite all the evidence that has not done a thing to reduce or to improve outcomes of baby, reduce cerebral palsy or oxygen deprivation and issues with baby. It has only increased cesarean rates by 3 to 5 times that of having just the intermittent monitoring, which is equivalent, but you're not attached to anything. And then, being told to lie flat on their back, no animal could labor that way. Naturally, women, when they're left to their own devices, need gravity. We need to be upward. We need to be moving and help. It's like, helping the baby navigate its way down the pelvis. The pelvis, as a chiropractor, there's 3 bones connected by ligaments. So on the back, it's smaller capacity, up and in asymmetrical positions and lunges and rocking and all sorts of upward positions. The pelvic diameter can stretch and is at the largest capacity. So all these things, I was setting myself up already, to not labor well. I was put on a clock. So I had to, dilate a centimeter an hour. And every hour, the doctor kept coming in, sticking his hands up me and going outside and telling the nurse outside the door, she's still 4, and give her pit at one point, I heard. Now, as a nurse, I knew what that was. So when she comes in and puts that in my IV, like if I hadn't been a nurse, they just do these things, right? But I'm like, I don't want Pitocin. That's going to make everything harder, stronger.
By the way, Pitocin is a hormone that increases the strength of the contractions, right?
It's a synthetic version of the natural hormone in my body that would have done just fine if they would have left me alone. But it was, so it's a synthetic hormone of what's natural in the body, but it makes it stronger, harder, and more intense. The contractions to speed up the labor. And I said, I told my colleague, the nurse that I work with, I don't want Pitocin. I know what that's going to do. And she says, oh, but honey, and her response was well-meaning. You don't want a cesarean, do you? And I'm like, no, I was an athlete myself. I'm a dancer. I yoga. I was scared of cesarean. I did not always see good outcomes during cesarean birth. And so I was kind of feared into it. I'm in a vulnerable situation now. And then my coping went out the window. I heard them say, give her an epidural. And once I had that epidural, my daughter's heart rate bottomed out so dangerously low that I see panic in everyone's eyes. They call a stat emergency cesarean. Now, as a nurse, I know they had minutes to get my baby out. I was now, my biggest fear happening, whisked off to the OR and waiting for the assistant surgeon. I was on the operating table, all scrubbed and ready, waiting for the assistant surgeon who never came. So I'm looking at the clock, I was alone, 10 minutes, 20 minutes, a half an hour, and 45 minutes, an hour. I had moved from utter fear to thinking that my baby is now oxygen damaged, going to be a vegetable, to now dead. Like that's in that hour, that was what I was convinced. Yeah. I didn't rationally know that in that time that the reason that continuous electronic fetal monitoring, one of the things that why it's not improving outcome and it just increases C-section is there's a lot of false diagnosis of fetal distress when there is none, right? But I didn't, so I started pushing when I was an hour into that from the medication. And I called for help. The doctor comes running in and he's in a frenzy, get me a vacuum. He's calling to the staff, and he cut a big episiotomy and he vacuumed, he suctioned her head out, and I couldn't look at her. I was afraid of what I was going to see, and she's pink and breathing and like not fazed by this apparently. And so she was fine. I was not fine. That was, now I know, I mean, I had all the symptoms of what they call PTSD, birth trauma, when you undergo such a horrific situation, the nightmares, the I couldn't talk or think about it. Any kind of trigger would trigger this whole sympathetic nervous system torture in my body, and I was scared to go back to sea. But, that happened, the same kind of birth I had a second time, just like that. So it was between that and experience and my working there that I was talking to a friend about my frustrations about this. And she says, why don't you be a midwife? And I said, what's a midwife? I mean, I literally said, what's a midwife? And she started telling me, and I went to the library, and it was like I came home and I applied, and I went to midwifery school. And it was like, it restored the whole experience. As a midwives, the training is extensive training. In New York, you have to have a master's degree. It's postgraduate training, and you have to be a nurse, but bachelor's in nursing and then a master's degree. And it restored the normalcy. It restored the power back to the woman and her family. It restored the celebration. It restored the beauty. And yes, we are experts in normal. Like, our philosophy is birth is normal until proven otherwise. But we can certainly screen for problems and handle them. Simply, we try to keep it simple. But what a difference. It was like night and day, and the crises and the emergencies became way more the exception than, and I was seeing that birth works. Like, women can birth like they breathe. And I went to I remember going to a midwifery conference, a big packed midwifery conference. And there was an obstetrician speaking, and his name is beloved obstetrician. He's a French obstetrician. He works in England now. And he said, what is the best intervention that a midwife can do at a birth, or an obstetrician? And he was speaking to midwives, but an attendant obstetrician or midwife can do at a birth. And his answer is brilliant. And he said, and it's kind of funny, but it's brilliant. He said to knit, K-N-I-T. And that is because, first of all, evidence-based care is that when a healthy woman goes into labor, first do no harm. Medical intervention is not warranted. The best intervention is no intervention, right? Just like women birth like we breathe, like our heart beats. We go to the bathroom. If nothing's wrong, don't fix it. The Hippocrates Oath, when doctors take their, in training, doctors take their graduation oath, part of that is first do no harm. So when all is going well, no intervention. But to knit is brilliant because it's this calm, seasoned midwife who's seen thousands of births and knows that everything's fine. And she's with the woman. And she's so calm that she can knit. And that laboring woman is so receptive to the calm. And if she sees that calm that's exuding, she'll feel calm and she'll labor well, because a fearful animal or a fearful woman or a tense woman, if there's tension in the room, she won't labor well. And the knitting keeps an attendant's hands occupied, because nurses and midwives and doctors, like they say, sometimes they need to fix something when they're in labor, do something with their hands. And nothing's broken, so you don't need to, so it just kind of keeps the hands occupied with the eyes open, heart is open, ears are open, and mouth is open. Of course, encouraging words when she doubts her strength, but she can put the knitting down if necessary. But that's the best intervention at a birth, and I thought it was brilliant coming from an obstetrician. So when I believed in all this, so when I had my second two babies, the midwifery way, I was still scared because I believed in it, but because of what happened to me, the trauma that I had gone through and what I had seen, I had to feel it within me, experience it myself, for me to authentically promote this for other women. And oh my gosh, when I remember my midwife saying, "Oh, you'll be fine," and it was beautiful. It was a beautiful experience, and it was very healing. I felt very well supported. My body just worked, and she was there as a lifeguard, but she just allowed and supported my body to do what it knew how to do. And so now I can authentically, and, you know, then I became very, you know, I opened up my own practice. I worked in a hospital practice for a while, and then I opened up my own practice. The hospital practice, what I opened, where I worked was, which is the kind of practice model that gets the best outcome. So I wanted to address your opening about how our country is ranking. We have horrid statistics in our country. We rank, you know, among the highest in the developed, compared to developed nations, in maternal mortality, newborn mortality, and morbidity, despite being the most technically advanced, having very high cesarean section rates, twice that of Europe, spending more money. Right. So what are the country? What's the common denominator in these countries like Finland and Sweden and Holland, Japan? Why are these countries with very similar demographics? It's not like they're healthier over there, right? Why are they doing so much better? So Dr. Marsden Wagner, who is a former he's a perinatologist, high-risk obstetrician, a formal maternal director of the Maternal Fetal Health Department of the World Health Organization, written many peer-reviewed articles, very scholarly books and articles, says the common denominator, and he's a big proponent of midwifery, because he says that's the common denominator is that in these other countries, when a healthy woman is having a pregnancy, she never sees an obstetrician, because healthy women need experts in normal, and that's what the midwife is. The obstetrician we need, thankfully, and they work together in a team, but they are needed for the high-risk situations, like if a woman has heart disease and she's pregnant, if a woman has insulin-dependent diabetes and she's pregnant, right? If there's triplets, right? That's their expertise. They go to medical school. They're surgeons. They learn how to deal with complications and disease and treat them medically and surgically. And, part of holistic care is sometimes we need that. My cesarean section rate's 5%. There is a time and a place for cesarean birth. It should not be 30% and higher, which is the national average. Some hospitals around here could be 40-50% around the country too. And so what he said is the common denominator is that both are using their expertise serving the entire childbearing population. But when you have in the United States this high risk kind of care, high use of surgery and medical and surgical interventions and technology applied to just the healthy women and babies, then you get the risk and the poor outcome that you're seeing. Right? Yeah. And that's the practice where I worked. It was this team of obstetricians, and they just said, just call us when there's a problem. They even wanted somebody with, let's say, who had high blood pressure, serious, insulin-dependent diabetes. They even wanted them to get midwifery care, and they would just deal with the medical issue or just call us when surgery is needed. But it was that team work, not that one is bad, one is good. It depends on the mom, what's that mom needs. But the vast majority of women having babies are healthy, and they benefit most from no intervention.
Yeah, and I think this is kind of the problem with our whole healthcare system in general, is we're taking this acute care model of care and trying to extend it to everybody, to well patient care, to chronic conditions, and it doesn't really work. And your concept of midwifery is very much in tune with both the chiropractic concept and the functional medicine concept, which is to respect the wisdom of the body, intervene just enough to help the body to heal itself, rather than taking over and intervening when it's not necessary.
Right. And I am just, the more I practice, I've been a midwife 22 years, the more I practice, the more I'm in awe of how little I have to do. I mean, I have a lot to do in terms of, there's a lot of fear now, and women have a lot of fear. They lack confidence. There's a lot of myths and misunderstanding. But I mean, when I help a woman to prepare in advance, for her pregnancy, and help her with her fear and her, and boost her confidence, and billions of women have birthed for thousands of years, and while she's birthing, 300,000 women are birthing. I mean, when I really help her to tune into her intuitive, primal, sensual, instinctual self, I am amazed at how I just catch. I mean, my presence there is there. I'm a lifeguard. I mean, sometimes I do have to intervene, but it could be simple, like, let's get up and dance. Let's go for a walk, go in the shower, make sure you're eating and drinking. It could be very simple stuff like that. That's all you need.
That's great. How much do you think the higher maternal mortality rates has to do with the rising rates of C-sections? We're essentially turning a natural process into a surgical procedure.
Yeah, huge correlation. That's major abdominal surgery. Most other surgeries, they're trying to make more laparoscopic. They're trying to make the incision less. But this is like a total major abdominal surgery, and it has huge risk. And unfortunately, that's hugely responsible for the high mortality rate in this country.
To play devil's advocate a little bit, and I don't really know if there's a difference, what the difference is between the U.S. and these other developed countries, but is some of this potentially related to the fact that we use, and I don't know that this is the case, I'm just speculating it, we use more in vitro procedures, maybe in higher risk populations, using hormones and medical intervention in the first place? In other words, do we have more risky, complicated pregnancies to begin with?
IVF, I don't think IVF in a healthy woman, once a woman's pregnant, it doesn't increase her risk.
Oh, okay.
If she's healthy.
Okay.
No.
Okay.
No, but what does increase the risk is like all the interventions, high rates of inductions, high rates of epidurals. There's hospitals, we live in a culture that likes to numb. We're not comfortable with discomfort. And right. but I help women in my practice, with whether they're through my practice or through my course or online consulting. I mean, I help them so that they can transcend the sensations, embrace the sensations. Just like if someone's running the 26-mile marathon, it's not easy. So I'm sure at mile 10 or 5 or 12 or whatever it is, something's hurting. They're thinking, I can't do this. And
right.
A lot of athletes and I'm a dancer, so I like to talk about professional dancing. But things are hurting, but their eye is on, I'm going to rock this, or I'm going to, win this for my team, or I'm, I can do this, and the beta endorphins and the hormonal recipe that's going on when an athlete is running or when a woman is giving birth helps numb the sensations and helps, and a woman could tap into her strength and she can do it. I have a 93% like women in my practice, and they come from all walks of life: engineers, physicians, nurses, chiropractors, acupuncturists, corporate people, and they don't have, it's not like they have different bodies. They're doing it naturally, 93%. That means that the majority of women are doing it naturally. Only 7% need to go, and I need to go to the, have medical or surgical intervention, right? My C-section rate's 5%, but I have not once had to transfer a woman to have an epidural because she could not cope with the pain of normal labor. That's
now I'm sure a lot of women, when they consider natural childbirth, they're going to say, well, if I'm not going to get an epidural, what am I going to do?
Well, the problem is epidural is contributing to high C-section rates and all the other, and the horrid statistics that we're seeing. Just think, even some people have had, I've had epidurals my first 2 babies, but I so preferred having my 3rd and 4th naturally. What a different experience. I'm working hard.
So the pain is not overwhelming?
No, because I'm up, I'm moving, I'm in the shower, and I'm also embracing it. And it's also like, I see labor for what it is, and I help women to see labor for what it is, right? So it's the uterus, it's coming and going in waves, and it's a healthy pain. It's a pain of hard work. It's not a pain of suffering. It's not a pain of illness.
And when you have natural childbirth, you're an active participant as opposed to a passive.
Yeah, we need the woman to be an active, and she moves in positions to help the baby. And it's like, her body is giving her messages to move in a different position, not just to help her cope, but to help the baby, it's physically navigate its way down. So I am amazed that I mean, not even one person in my 20 plus years of my own practice have I had to have transferred because she needed an epidural for normal labor. When you need to be well prepared, but like just even seeing labor for what it is. Like, here's an example. So in the beginning, do you have kids?
Yes.
Oh, okay. So
I have two older kids. Yeah.
Okay. So you've seen labor, unless she.
No, I have. Yeah.
Right. So in the beginning, the wave comes, and it's like, I like to call it wave because contraction implies tension, and it's not completely accurate because the top of the uterus contracts so the bottom can open. So it would be just the same to call it expansions, but hypnobirthing, they call it surges, and waves, you can call it waves. I've had women make up names like hugs to the baby. You could play around with it. Why not have fun? Why not make this like an adventure of a lifetime?
Right.
And because it's like totally a healthy. I've had women be in ecstasy with their pain. I've had people explain their. I mean, I'm in the documentary Orgasmic Birth. Not that women are having orgasms in birth, but they're tapping into their sensual, and their experience is orgasmic. Because they're doing it on their own, and they're so darn proud of themselves, and they're being honored and treated as like a goddess and a warrior. Like it's the power is restored to them, and yes, they need support, but anyway, seeing labor for what it is. So yes, the contraction, the wave builds, in the beginning, and it reaches a peak, and then it comes down again. And in the beginning, that might be 15 seconds, right? And then there's not another one for 10, 20 minutes, and they're mild. You can talk through them. So it gradually builds. So at the max peak intensity, the wave is maybe 60 to 90 seconds and coming every 2-3 minutes. But the peak is really where it's the most intense. And I'm like, you can do anything for like 45 seconds, right? So get a now clock. Instead of saying 1, 2, 3, 4, 5, just say now, and you just stay in that one. And, I teach women, and women can learn coping, relaxation, grounding, visualization, or just sort of surrendering to it. Like, wow, like just it's like when you fight the wave, what any surfer knows, when you fight the wave, it will knock you down, right? But if you just ride the wave, it will just take you.
That's great. Childbirth like surfing.
But it's so similar.
Yeah.
And there comes a point, and it's part of the psychological different stages of early labor versus, when labor gets more intense, right before the baby's born. Women will say to me, and these are women hardcore, I've had women chiropractors, husbands, a homeopath, and natural, and like, she's in transition, she's in the last part of labor, and she's like, I want a cesarean. I can't. And I'm like, that's great, baby's coming soon, meaning I prepare them that they're gonna think they can't at the end. That's just normal part of the emotional symptoms of having such intense sensations. And it's when I encourage them to just, what, I got you. Just go into it. Dive right into it. Mindfulness practices, meditative sort of just dive right into it. Or I'll have women will sing their baby out or dance their baby out, and like sort of pleasure overrides the intensity of it, but just like give into it. And then they find that the actual the fear of feeling was actually worse than the actual sensation. And then they birth, and then it's gone. It's done. Then the real work begins of raising healthy, normal children in this world.
So why don't they let women eat or drink?
That's not evidence-based care. Add it to the list because of the rare need for general anesthesia in an emergency. That if she were to have food in her intestinal, in her upper GI tract,
esophagus,
she would aspirate. But that's actually the food would make it it wouldn't affect, meaning the evidence, according to all the scientific evidence, it is beneficial for women to eat and drink in labor, and it's harmful to deprive them of food and drink.
And even if they were to end up with a cesarean section, most of the time they use an epidural, right? Yeah.
Yeah.
Okay.
So
can you talk about some of the processes that occur after the kid is born, and, how the hospital handles it compared to, how it should ideally naturally be handled?
Well, one of my pet peeves is the cord clamping. So yeah, we're the only species on the planet that cut cords. Animals don't cut cords. Animals give birth. It's just not complicated, and it's cool because like dolphins, they have female dolphins that surround them. There's like dueling them or midwifing them. Llamas will sit, the pack surrounds them,
but we got to schedule, the insurance, and we got to go bottom line, we got to
bottom line, but unfortunately it's not serving the mom and her family and the baby. Yeah, one of my big pet peeve I have is that a third of the blood volume of the baby, that's a lot of baby blood volume, backs up into the placenta as the baby's pushing, as the mom is pushing, as the baby is coming through the pelvis. And when the baby is born, the baby needs that blood back. I don't know why this has started happening in the early 1900s when birth was moved to the hospital, that the cord was just clamped. So the baby was deprived of a third of its blood volume, which is equivalent to a hemorrhage that no one sees.
Wow.
And so those babies were lacking the stem cells and oxygen to transition, the blood volume to transition, all the immune components, iron,
colostrum. Yeah.
Well, the colostrum is in the breast milk. This is blood. This is their blood. This is right. So that's a big thing. If you're going to have a hospital birth, make sure that's evidence-based care. This is, the process has worked for thousands of years. Don't cut the cord. Allow the cord to just give the baby back its blood volume. You can cut it when the cord stops pulsing, or just wait till the placenta is birthed and cut it. And that's a big thing. They're sticking suctioning tubes down babies that are vigorous, just to clear lung fluid. Babies in the womb, their lungs are collapsed and filled with fluid. They don't need to breathe because the cord is giving them mom breathes, it goes to her blood, and then the oxygen goes from her blood through the placenta to the baby through the cord. So the baby doesn't need to use the lungs. But after the baby's born and takes that first breath, the baby needs the blood volume and the oxygen from the cord to help as it's transitioning. And the baby, with that big squeeze through the vagina, clears a lot of the lung fluid, at least 2/3 of it, and then the other third gets absorbed. Babies don't need to be suctioned. We're sticking tubes down their trachea to suctioning vigorous babies, and then they take the baby away from the mother and put it on a warmer, bright lights, and they're doing all these procedures. That baby needs to be with mom. I mean, just think, the baby had 24-hour womb service for 9 or 10 months, and warm and quiet and close to mom, and then suddenly born with the modern medicine does not, the majority, I mean, there are some wonderful practitioners that that are into this cutting edge research, that actually babies are born fully conscious, and there's a huge, profound psychological impact of birth on both mother and baby, and babies are very receptive and sensitive to rough handling and all these procedures and things that are just done to them routinely, when all they need is to be, when a healthy baby is breathing and vigorous, they just need to be with mom, never separate. Any procedure that or exam can be done with mom holding baby, or baby next to mom, or partner next to mom. So these are some things. They're also giving in the hospital the hepatitis B vaccine to all babies.
What's the point of that? That's crazy, right?
Because they're in the hospital. That's why we get them now. But yeah, the hepatitis.
There's zero risk of hepatitis B, for an infant.
And a newborn, especially if mom is negative. if mom is negative, right, because hepatitis B is spread, it's like HIV, it's in the way it's spread, but blood and body fluid. So if the baby's going to do IV drug use or promiscuous sex, or be a doctor, an obstetrician, and get needles, have a blood exposure, some risk or something like that. But yeah, there's no need for the baby to have hepatitis vaccine, but that's just become routine. So there's a lot of things that are done that, and I tell, like in my course or in my practice or with women I work with online, I there's a list of now it's 50 things that you have to be aware of what could be done to you if you're pregnant, have a birthing, or for the baby, right? And so just let's discuss the pros and cons. Let's research this now in the pregnancy so that when you're in the heat of it, you already know, we'll make a list of what you want, what you don't want, right? And make that, communicate that with your provider in your setting so that your wishes can be honored as long as there's no crisis, emergency, and make that known so that when, because if your baby's taken to the nursery, things are going to be done to your baby. You might not even know anything about it.
What about circumcision? I know that's a controversial one.
Well, it's a harmful, it's genital mutilation. It's babies are born. I mean, the thing is, it's I don't really think it's controversial.
Okay.
Meaning I
weren't there a few studies that showed there's a decreased risk of genital infections or something like that?
Yeah, it's not supported as a medical necessity.
Okay.
Right? Babies feel pain. Now the thing is like, I'm not getting into the religion, like some religions,
Right. No, I know.
I'm talking about medical circumcision in a hospital. Unless the baby has a problem, there's no medical need for it. And, babies feel pain. It's traumatic. They tie the baby down, and it's the baby is born in a certain way. Why cut off part of it,
Yep.
Yeah. But I have some moms, for example, I would say now about 50% of my practice don't circumcise. I mean, I have some moms that or come to me and her husband's circumcised, and she might have other kids that are circumcised, and she doesn't want the baby to feel funny or picked on in the locker room or something like that. But more and more and more boys now are not circumcised, so that won't be an issue. And I've had plenty of moms who have some circumcised from when they didn't know about it and are not circumcised now, so I give them that decision. That's their decision, but they need to know the pros and cons. I want that to be an informed decision. Unfortunately, the baby can't make that decision.
Great. So
they grow up and they're like, why did you, because babies remember trauma. That's nonverbal memories, right? And they can heal from that, but it is a traumatic experience for the baby.
Yeah.
They're
Cool.
fully conscious. They're fully aware.
This was great. A lot of really good information. I know you've written several books, and you have at least one online course to learn about how to have a healthy natural birth. Can you tell us about these, and also how listeners can get a hold of you or learn more about you?
Sure. I was the course. So I was interviewed on a podcast a few years ago. And the woman that was interviewing me, she said, "I love your approach," or whatever. "Do you travel?" And I'm like, "Well, if you're in Hawaii," or no, I was like, we were playing, I was
yeah.
like,
Yeah.
He's like, "Do you have a course? Like, how do you, I would love if you would have a course." And I'm like, "I don't." She says, "Well, you need to make one. How about if you come out to San Francisco? I'm into film, and my sister's an editor, and I want to film how you bring people through your practice, and we'll make a course." And so that's how the course started, because I started posting on social media, when my daughter told me I should be on Instagram, and I asked her, "What's that?" She said, "Oh, you get all these great pictures and you're so passionate, and here's the 101, and just, you like spreading the message of improving birth and mother baby experiences and care and things like that." So who knew? It became, in a few years, 81 or more thousand followers on social media. So I'm hearing from people all over the world.
That's great.
Asking me the same questions. So the course I thought was a great idea about, how to prepare for I call it like a home birth like experience in the hospital, in the birth center, in the home, a normal, natural, physiologic birth, and also how to embrace complications and embrace a cesarean birth if needed. But how can you rock your pregnancy in mind, body, heart, and soul? And it's how how I prepare women in my practice, except without the hands-on care. So that's my course. I mean, I poured 22 years of wisdom and experience of what really works to help a woman. Well, at the time it was, I actually took her up on it. We went out to San Francisco and we filmed the whole course. It's 10 video, and at least hour-long videos, plus a lot of downloads. And then there's an option of consultations with me. And I have a book that's called Natural Birth Secrets. It's released on Kindle. It became a #1 international bestseller, and it's coming out on paperback. And then I have another one, Ask the Midwife, and then another one about trauma healing, because there's so many women. This is a big specialty of mine. Is so many women come to me traumatized. So 4.3 million women are giving birth in the United States, and over a third describe it as a traumatic experience.
Wow.
So I'm hearing from so many women that how can I help them? They had a horrific, traumatic experience, kind of like I did, but everyone had, maybe a little bit different details, but not that much different. And how can I help them heal, and how can they have a better experience next time? So that's called the trauma release formula.
Okay.
And so my website is called homesweethomebirth.com. Great. And my course is Love Your Birth, and they can you can download when you go on that. There's a free webinar about birth trauma and preventing it. There's you can download a little nugget of the course, which is about what I said, preparing a birth plan and all those 50 different things that could possibly happen and what you want to do about that. It's important to know that and discuss that in pregnancy, because if you decide that what you want is not in alignment with your provider in your setting, you can absolutely switch providers and settings and know that you have a choice and you have a voice, right? And there are plenty of supportive obstetricians and hospitals and midwives. You just have to do some research. Unfortunately, it's not available. I have time for a short story?
Oh, sure. Yeah.
Oh, okay. So a woman took my course. She only had access. She was in a very remote area, and she only had access to an obstetrician who did cesareans. That's all. That doesn't even do natural birth, doesn't even do vaginal birth, and that's all she had. And
wow.
She took my course, and she found her voice, because I tell women that hospitals and midwives and doctors, we're not law enforcement agencies. Actually, we need to respect your autonomy, and your right. And she developed knowledge is power, and she developed her confidence and her belief in her body through taking my course. And she said to him, "I don't want a cesarean birth. I want a natural birth." And he's like, "I don't do natural birth. I don't even do vaginal birth." She says, "Well, you're going to do that for me. That's what I want." Well, he agreed, and she sent me a video. She had the most beautiful birth. But just think of the ripple effect. It changed him. How is that going to affect all the other women? Cool. That, so that's where change comes, is when we empower women and their families to speak up.
That's
respectfully.
Great. Awesome.
Yeah. So
cool. Thank you so much, Ann. I know the listeners are going to love this podcast.
Oh, I'm so glad. Okay. I love talking about it. The more, this is how we change. This is how I think we change the world, is sharing our passions with the families to take back their health, to take back their birth.
Exactly.
Right?
Excellent. Perfect. Totally in alignment with my mission.
Oh, good.
Okay. Talk to you soon. Bye.
Thank you. Bye.